My name's Teresa Villaran. I am the moderator for tonight. I am the chair of the Professional Nursing Practice and Advocacy Cabinet for the Kentucky Nurse Association. I'm also the president of the American Nephrology Nurses Association Bluegrass chapter. Our panelists tonight for our intersection of social justice and healthcare, the waiting room, will be Patricia Coons Howard. She is Enterprise Director of Emergency Services for UK Healthcare, the EMS Training Coordinator for the Lexington Division of Fire and Emergency Services, and an adjunct professor at the University of Kentucky of Nursing. She has a doctorate, a Master of Science, and Bachelor of Science from UK College of Nursing, and an associate degree in nursing from Salem College. Welcome, Dr. Howard. We also have Laura King. She is the Director of Emergency and Cardiovascular Services at Baptist Health Richmond. She has a Master of Science in Business Administration from Union College and a Bachelor of Science in Nursing from Eastern Kentucky University. She also is a SANE nurse. Welcome, Laura.
Yeah.
I also want to welcome Chris Hsu. He is the nurse manager of the emergency department at St. Elizabeth Healthcare Covington. He has a Doctor of Nursing Practice from Northern Kentucky University, a Master of Science from Western Governors University, and a Bachelor of Science in Nursing from NKU. Welcome, Dr. Hsu.
Thank you.
All right, let's get right into it. We're glad the mayor came, but he took a little bit of our time, as you know, politicians tend to do. But we're grateful for him. Okay, so my first question for the evening is, how do you define fragmented healthcare? And does the film show any examples of this fragmentation? Let's start with you, Dr. Howard.
Well, I think when I think about fragmented healthcare, I really think about those who are unable to have a continuity of care and truly access to care. And certainly there are many examples. I think about the young gentleman who said, well, if I'd known it was really going to be an emergency, I would have sought care sooner. And I could go on and on with several other examples, but certainly the whole highlight around this film was really about fragmented care, because we know that's one of the challenges of the emergency department. We are not continuity of care. We are episodic care, but we are the safety net and we are an access to care point.
Thank you. What about you, Laura? What do you think about fragmented care, and did you see some in the movie?
I did, and I would agree with Patty as far as she's talked about the continuity of care, the available resources. The one thing that caught me in the movie that I actually backed it up is when he said the ED is not a place to manage overall health. And as she mentioned, we will fix the acute problem, but there's so many problems that we never get to the bottom of. So I would totally agree. When you say emergency department care, you are discussing fragmented care at our best. Even if we try to get the care navigators, the social workers, at the end of the day, we can't possibly give you the full experience and the whole holistic experience that you deserve.
Dr. Hsu?
I agree. You know, it's a lack of continuity of care. Also decline in care because of ability to pay. Referrals, lack of referral shift, maybe because of the patient's lack of ability to pay, as you saw with the patient that was at Kaiser and then had to go to Highlands Hospital, fellow with the tumor. And in our emergency department, we see this stuff all the time. I recently had a patient who had his jaw broken and he needed a surgeon. And so basically the contracts with the hospital, oral surgeons are not required to be on call 24/7. So long story short, I did get him into UC, but it took, you know, multiple phone calls, resources, and actually a nurse that I knew to get him connected. So I think this film did a great job also of showing that.
A study from 2017 indicated over 47% of medical care in the US is delivered in the ED. That's a lot of medical care for the ED. Would universal health care change the type of care we saw in the film? Let's start with you, Laura.
I think it would be hard to say. And the reason I say that is I am married to a British citizen. So when I hear his family talk about universal health care, especially when we discuss people that come to the emergency department here versus the wait times there and what they really define as an emergency. So I would say formulating this now would probably be very difficult, because I do think it would result in longer wait times. I love the idea that everyone's on the same level playing field, but I think it would be very difficult in today's times to kind of back up and repunt and go into that, just because I hate to say, but we're kind of spoiled with healthcare on the ones that are insured versus uninsured. So it would really be a toss up for me, just hearing their experiences and hearing what we would consider a run-of-the-mill emergent surgery is they're on a month-long or months-long waiting list to have that surgery. So I'm probably the worst person to answer that question, quite frankly.
Okay, what about you, Dr. Shu?
I agree. I'm kind of on the fence. I don't know. I mean, I think we would have to allow it to be in place for a significant amount of time before we would see the results, if it would significantly improve it.
Mm-hmm.
And I would think that if it was the case, that we would have, delayed times, as in other areas where universal health care like Canada is in place. So I'm kind of on the fence about it.
Okay. Dr. Howard?
So honestly, I think it's a yes and no answer, which is pretty much what my colleagues have said. But the reality is universal health care is really not the fixer of all, unfortunately, because you've already heard people have to wait to get care that they need. And unfortunately, sometimes because they have to wait, they become sicker. And so their outcomes are not always as good as they could have been. Even in our fragmented system, they would have gotten potentially care much sooner than in a universal care system. So Laura talked about her husband's family. My cousin was living in England and needed her gallbladder out. And she could not get her gallbladder out for 4 months. And unfortunately, she got actually a septic gallbladder and became very ill, and then had a much longer trajectory in terms of her return to baseline than she would have had if she'd had a cholecystectomy early. And so while I think there's many advantages, and I think it's nice that everybody in theory is on a level playing field, the reality is I don't know that the outcomes are better. And I think when the day is done, that's really what we need to look at is, are the outcomes better?
Right.
Okay. What role can nurses play in changing a system where the ED may be the only access to care for certain populations of patients? Dr. Shu, we'll start with you.
Certainly patient advocacy for sure, care coordination, and serve as a resource for the patients to get them connected to where they need to be. Certainly major component of emergency department nurses would be discharge instructions and providing adequate follow-up after that, of course. So I think the major role of the ED nurse would be that they would be the patient advocate and, play a role for care coordination, I would say.
So kind of like a nurse coordinator for care.
Navigation, nurse
Navigation, yeah, a nurse navigator. Yeah, sure. Okay. What about you, Dr. Howard?
So I'm going to take advocacy in a little different direction on this one, because I think one of our key roles here is around policy. I think that we have a great opportunity to educate our policymakers as well as the public. I think that's really one of our key roles as we try to make a difference here is they have to understand the importance of access to care and continuity of care and all of the aspects that we have to consider on a day in and day out basis when we try to manage care.
Great. I'm glad you mentioned that, because a lot of times nurses don't consider policy part of what they do. And I agree, we need to do a little more of that. What about you, Laura?
I would totally agree with Patty. I think in addition to care navigators, I often think of the times, I'll read the 20 pages of discharge instructions that are given to a patient, and I literally get 3 pages into this and think there's no way that they're understanding it. They're not even understanding the importance of show back up tomorrow to your primary care. I think to her point, as far as policy, I tend to look at the patients that we all know them in the emergency department that we say, oh my gosh, like how have they fallen through the cracks so many times? And I look at advocacy from the point of talking to the patient, but then I also look at it from the side of who has failed them so bad. I think of the ward of the state that has caregivers that can't even tell me the name of the caregiver, or that has all the resources that he would want, but doesn't know how to access any of those resources because they don't reach out to them. So I think it's really trying to get at everybody's educational level and honestly just emotional level to be able to take in all that information, to give somebody a terrible diagnosis and then a discharge packet this thick to say, okay, you've just been diagnosed with cancer. You're going to do this, 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 and this. They have heard nothing but you were just diagnosed with cancer. Beyond that, nothing else like sticks with them. So I think that there's a lot we could do, but it would take a lot of external resources. And I think that tends to be the problem, is the ED can't fix it all.
I agree. I saw a film, and these daughter and wife took a patient home and had to do wound care and all kinds of things. And their comment was, you know, we wanted to bring him home, but nobody taught us how to do this care.
No.
We had to learn it on our own.
Right, right.
So I think you're right. I think if there was just someone we could refer patients to that could help them understand, you know, what to do, that would be great. What are the consequences in delivering care to psychiatric patients in the ED? And just kind of to add on to that, you know, we're going to be seeing, I think, a lot of psychiatric illnesses because of
Right.
the pandemic. You know, people have a lot of PTSD. And a lot of that is dealt with in the ER. So what are the consequences of delivering that care in the ED? We'll start with you, Laura.
I would love to take this question. So I am also the director of behavioral health services. So I do see a lot of this without giving any information. We just had the same conversation about this last night, with when the patient presents and you want to acutely fix that problem in the emergency department. While we want to fix the acute problem, we tend to not be able to fix because we don't offer all the wraparound services. So what we typically do is we put the Band-Aid on it. We find the best place to go that's going to treat the problem, but then we don't do the wraparound services. We don't offer the counseling. We don't offer any of the outpatient stuff. So, and Patty, I'm sure, and Dr. Shu, you can agree. So we see, you know, in the movie, they described that they knew the same patients. We unfortunately have seen these patients, and now we're seeing these patients' children. They're dealing with this, and you look at it and you say, we have failed them. And when I say we have failed this patient, the government, ourselves, because this patient has fallen through the cracks. You know, I said to one of my doctors, he wouldn't know to bring himself out of the rain. How can I expect him to know to take his medicines? So I think that's really it. We can tip of the iceberg fix the problem in the emergency department, but it is going to take so many resources and so much advocating. Because if you've ever dealt with that population, it's extremely burdensome to just say, I need you to call this number tomorrow morning, is taxing to them. That's a lot of responsibility to put on them. So I think while we're trying to mend the problem, we're not fixing the problem.
Dr. Howard?
So I actually think one of the biggest challenges we have in the emergency department is behavioral health care. I believe that it really contributes to, yet again, very poor outcomes, long length of stays, significantly fragmented care. And unless you work in a psychiatric emergency department, we really don't provide care. And I hate to say that out loud. I feel very guilty saying that, but the reality is we are watching them and keeping them safe, but we really are not addressing the primary issues because that's not our specialty. It's not our area of expertise. We don't have those services. And so while they're in a warm, dry place with food and probably some type of medication, we are not addressing their global healthcare issue. We are not ensuring that they're going to be able to return to their community in the highest functioning possible level. We are really just a stopgap measure. Mm-hmm. And so I really feel probably the most sad about the care we deliver to patients with behavioral health issues.
Mm-hmm. Dr. Shu?
I would agree. I would agree that many times they exacerbate in the emergency department. I know, you know, in the system that I work in, we experience a lot of holds with these patients. They're staying in the emergency department sometimes for 6, 12, 24 hours, especially adolescents. I've experienced a lot of patients that kind of get worse while they're here, or maybe they'll act out or something. So we wind up medicating them, things of that nature. So we're not providing any kind of therapy for them. We're basically holding them in a holding pattern. And it's a terrible injustice that we're seeing right now, especially in Northern Kentucky.
Oh yeah.
I mean, our environment's subtherapeutic for most of this population.
Yes.
Yeah, and I think that, I mean, we've always done a terrible job with, you know, behavioral health problems. I think it's just going to get worse, unfortunately. If you have any questions, please put them in the chat box and we hopefully will get to them. I'll ask one other question and then we'll get to the audience questions. We kind of answered this question, but can you just give me one thing that you saw in the documentary that demonstrates a gap between administering healthcare to uninsured or underinsured patients versus those who have insurance? I'll start with you, Dr. Howard.
I think about the patient, and I'm going to say it was his wife, but I don't know that for sure, that his wife was very worried about him because she was very worried that the bullet that had been left in him was continuing to move. And I think about that, and most of the time we don't leave bullets in patients. I mean, there are some unusual circumstances where we do, but typically they're not patients that are discharged either. So I think about that particular circumstance, and I think about how frightening that had to be, particularly given the symptoms that she said he was describing. It's concerning because this was their access point, and they felt like they weren't getting the care that they needed. And I mean, I wasn't there, so I can't say that they were or they weren't. But it is disturbing to look at. It doesn't make any of us look good in the healthcare field, for sure.
Laura?
I think there was lots. I mean, we talked early on that when you look at this movie to me just depicts sadness, but I think that's the life of the emergency department. But the one thing I would say is what I kept thinking the whole movie is I could go to the doctor for one thing, and while I'm there, mention a couple other complaints and really treat myself could treat the whole patient. I think that's what tends to miss on our patients, and the fact of we have very limited time to try to fix the acute problem that you came for. So while all the other problems are important, that's not the acute problem that we're there to fix. And often we do a couple of them, but for most of these people, we are their primary care doctor. So it's unfortunate because you want to spend the time and you really want to help them, but then you also don't want to be, I mentioned a lot about people slipping through the cracks, and I don't want to be one of those people, but I sometimes feel like, wow, could I have spent more time? Could I have done things differently? Could we have looked into that, his feet, because he's homeless and he trenches all over the county. I think that's the tough part for me is it's a luxury when you really watch that movie and think, I can go to the physician and he's going to spend 20 minutes with me. We are their primary care for a lot of these people. So it probably opened my eyes more to just slow down sometimes and let them talk it all out. And maybe we can't fix it, but maybe there's somebody I could try to refer them to in the patient hub or something to where they have that ability that I have.
Dr. Shu?
The patient that had the dialysis, I think that was, we see that here.
Yeah.
Sometimes we actually are lucky because we have a clinic that's, I work in a freestanding emergency department. We actually have a dialysis clinic that's part of this complex, but I totally related to that because we all know that when, they don't get their dialysis, they're in trouble. They're headed down the wrong road, period. And I really felt bad for that patient because he didn't know why they kept sending him back there, to Highlands.
Right.
I didn't understand it really either myself. I was like, what? Hold on. Like, I want to get in there and ask him some more questions about that. But there was a lot of examples of that, but he stuck out in my head. And then the fellow with the tumor again too, that was at Kaiser.
The patient with the dialysis really struck out to me because that's what I'm doing now is dialysis. And in our discussion groups, we always talk about patients who are immigrants, who maybe the only place they can get their dialysis is when they come to an ER, and then it's like every 2 weeks they'll get a dialysis or whatever. It's not on a regular basis. So he really struck a chord with me too. Delano, do we have any questions in the chat box?
Actually, we have some incredible comments that I would like to share.
Sure.
One is from Dr. Grant, and he said that he was so incredibly pleased to hear Dr. Schwick talk about discharge instructions. It's quite apparent that those in the ER who have previously been seen either at Highlands or other hospitals did not understand what they needed to do as part of the follow-up steps. I thought that was just an an awesome comment.
Mhm.
Also, there's a comment that says, thank you, Dr. Howard. Advocate for better access to care, not only access to emergency safety net and services, but increase access to primary care services, population health versus medical model. That's from Dr. Brittany Welch. There was a comment from Marilyn Dollinger. I'm very surprised at the negativity of universal access. I'm from Canada and I clearly see the advantages.
Thank you.
Laura, I want to go to your doctor. That was from Ellen Puckett. And then I think that the comments are very appropriate to the panel and to the movie. And all I can say is thank you all for being here with us. And so, Teresa, if you'd like to take us to the next level.
Sure. I thank all of the panelists. Every time we've done this, it's been a great discussion. So thank you so much for being here. We really appreciate it. We know that you are giving your time to this project, so we really do appreciate it. We hope that everyone will join us for our 5th movie night. It'll be on May 27th. It's from 7 to 9, and it's actually about the providers this time. It is a documentary looking at a nurse practitioner, a PA, and a doctor in rural America, and how limited resources and the opioid epidemic is affecting the providers. And it's very powerful looking at from their point of view. This film also kind of is the tail end of our Nurse Suicide Prevention Month. So it fits perfectly into that. Keep a lookout for our free CEUs for Nurse Suicide Prevention Month. The KNA has been very gracious in offering every Thursday a free CEU offering. So we appreciate the KNA doing that. If there are no other questions, thank you all for being here, and thank you for the discussion. It was very powerful. Thank you.
Thank you.
Thank you.
Thank you all. We appreciate
Thank
you being
you.
with us.